Mukherjee. Before you all joined us, I asked Dr. Mukherjee where he was, because it all looks very glamorous and I'm in my bedroom. But apparently this is a virtual background, and I just feel you should know that. And for those of you who don't know Dr. Mukherjee, I have sent my patients to Tanmoy for, how long? Like 20 years now.
Let's not say. Let's not say. It's Zoom. We can kind of imagine those things now.
And I consider him to be such a good fertility doctor, such an experienced, smart fertility doctor. And normally he's too busy to hang out with us on Zoom, I think. So this is one of these nice things about being on lockdown, isn't it? You get access to people you wouldn't normally get access to. So I'm happy to see you, Dr. Mukherjee.
Jill, it's been a pleasure working with you, and I'm glad to have this chance to sit with you and talk via the new reality. But it's a good way to get information across. It's a good way to keep moving and stay fresh in these challenging times. I hope everybody's healthy and safe. So let's get started.
And talk to us in the chat, you guys, and we'll pick those up. And I just wanted to say that for those of you who don't know me, and I see many familiar faces, I'm Jill Blakeway. I founded Yinova in New York City. We are a practice of very experienced acupuncturists and clinical herbalists and fertility coaches and body workers. And there are, I don't know how many acupuncturists we have. I think it's 27 of us in 3 centers, and we're all at home and we're doing virtual fertility coaching. And I'm the author of 3 books. And the first book I wrote with the doctor, and it was called Making Babies. And that was 10 years ago. It's still in hardback because they tell me it sells as well today as it did then. And then I wrote a book about sex because my fertility patients told me that they were never going to have sex again by the time they'd done this. So I wrote a book called Sex Again, and my latest book is called Energy Medicine, and I got to go off around the world and talk to scientists and healers about the sort of energetics of how we connect. And we're kind of leaning into that book at Yinova at the moment because we're energetically connecting with our patients on Zoom, but we're also giving lots of fertility coaching, and we have fertility coaching groups starting in the next week. So we're looking to give people support. And Dr. Mukherjee, one of the things that my patients are saying to me is they want to use this lockdown time to work on their fertility. They don't want it to be just something they're, sitting at home doing nothing. And I wondered what your thoughts about what people can do at home to take care of themselves.
Well, I think it's an excellent question. Fertility is a process. It doesn't start the minute your medications start. You want to anticipate, you want to modify diet, take good care of yourself, consider supplements, alternative therapy leading up to treatment. Can everybody hear me? Can everybody chime in and ask questions as well? Because I'm seeing a lot of mute and unmute here. So if you have any questions, raise your hand and I'll see what I can do.
Or just write in the chat and I'll
even better.
Grab them from the chat. I've got the chat open. I'll see, but we're happy to answer your questions.
Right. So
we're here for you.
Patient of a cycle, which is what I think we all should be hoping for. I do think that IVF fertility services will resume mid-May, June at the latest. Our practice is starting up with medication now. So I think that there is a good lead time before active fertility management starts. And as Jill and I have worked on before, it's mind and body experience. I mean, clearly, to get oneself together to pursue IVF therapy, you need to have a certain amount of resilience, and the times such as they are, it's very difficult. So exercise in this period of time, whatever you can accomplish, is a good idea simply to get in a better frame of mind. Actual physical interventions in terms of diet, in general, moderation and everything, alcohol consumption is something that, given the current environment, is something that just has to be paid extra attention to. Not that you have to eliminate alcohol consumption, but you certainly want to moderate it. And by moderation, I mean about 5 to 7 alcoholic beverages per week, no more than 2 in any given day. Supplements, which I'm sure Jill will chime in on, but anything that will improve your metabolism, improve your health. Clearly, if you have pre-existing medical conditions, if you're diabetic, for example, or pre-diabetic, then you certainly want to modify your diet such that you're compensating for carbohydrates, watching your total caloric intake, and exercise becomes even more paramount, and reduction of alcohol. moderation of caffeine falls under that umbrella as well. So a lot of the approaches that I use prior to treatment involve just getting your mind and body in balance, watching your diet, watching exercise. Don't exercise excessively. Moderation in everything is critical, and as Jill comes from the Eastern philosophy here, and I think that bears truth for all aspects of what we do in medicine. It's a balance, no extremes. I have a lot of patients who are very aggressive towards their approach to exercise, and it's an important part of their well-being. So I never ask anybody to stop, but I do ask them to moderate as best they can. Jill?
Yeah. And I think this is, I agree with all of that. And that one of the things I want to say, because this comes up when, we see our patients every week and we talk to them and we listen to them. And I always tell people I've been listening to women's hopes and dreams and fears for 25 years. So I sort of, have an ear for what we do with information. And one of the things that fertility patients do is they start to blame themselves. So I think it's really important to say, I like the message of moderation for this reason. If you've been suffering from infertility, and not everybody in this group will have been, it's not your fault. These things are massively random, and people who have extraordinarily unhealthy lifestyles get pregnant, and people who have really worked at their health sometimes struggle. And honestly, as practitioners, and Dr. Mukherjee will tell you this too, we just know that this to a certain extent is random. But when you are struggling with infertility, it starts to be a case of sort of statistically tipping the scales in your favor. So it wasn't that you were doing anything particularly wrong, but now we have to sort of up the ante, and we have to tip the scales in your favor. And so a healthy diet is helpful. And Dr. Mukherjee will tell you that the hardest people to get pregnant are the people who are missing something from their diet. So if they have absolutely no fat at all, which used to be a thing when clearly we've done this for a long time, but everybody was on low fat diets. And those people, you do need fat to make reproductive hormones. So those people were a struggle. Sometimes vegans, if they're not really good at getting protein, are hard to get pregnant for the same reason. And I remember having this conversation with Dr. Mukherjee, so I know he agrees with me. And these days, the people who are just doing keto and all they have is animal products and fat, that you do need some carbohydrates also. So the moderation in all things is true, isn't it, Tanmoy?
Right. Thank you, Jill. We have a question here. Should we take a chance to talk about diet and such on this particular question?
Well, it's actually a really good question. Thank you for this, Jenna, to talk about now. You see, you're really good at this, Dr. Mukherjee, because PCOS can often be helped with diet. There's an element of insulin resistance to PCOS that responds really well to a low sugar diet, including, I hate to take people off carbs altogether because I don't think it's good for them, but some kind of, a very limited amount. And to answer your question, and I'll let Dr. Mukherjee tell you what he would do, it is frustrating when you only have a period every 34 to 45 days, because it does cut down the number of times you can conceive in a year. And there is some evidence when we all get back together that acupuncture actually helps people with PCOS ovulate. And I mean by that clinical evidence. And they actually did, this is kind of funny, but they did the research to start with on rabbits who apparently are anovulatory until they decide to have sex. They don't ovulate. And so they're actually good to test on, poor bunnies. And they found that they could use acupuncture to get the rabbits to ovulate. Without them being in a position to mate. And the same woman who did that research on the bunnies then did research on women with PCOS for the same reason. And they found that the same protocol that worked on the rabbits actually worked on women with PCOS. So acupuncture is a good way of getting you to ovulate earlier. We also do it with herbs in our practice, and we can do this while you're on lockdown the Yinova team are doing fertility coaching consults, and you can just go on yinovacenter.com and book an appointment and see them. Some of them are here actually, and they're the smartest group imaginable. But we use Chinese herbs to support a good follicular phase, and then help you to ovulate in a timely manner, and then support progesterone in the luteal phase. And we can usually get it down a bit. But it is a good question when it comes to diet, isn't it, Dr. Mukherjee, with PCOS?
I do, and Jill, I think that's a great answer. I'm just going to add a couple of things. My big frustration with polycystic ovarian syndrome is that it's a terrible name. It's a terrible diagnosis. It is not a single disorder. It just means that you're not ovulating on a regular schedule. So while I'd love to give a nice short answer to this question, I think the critical thing is that you should be evaluated, because what feeds into this diagnosis? As you pointed out, insulin resistance, diabetes, yes, but also thyroid disorders, cortisol disorders. There are a number of different medical conditions that may affect your ability to ovulate naturally. And you certainly want to have an evaluation to make sure that these hormones are in check, because if your thyroid is out of balance, you'll have irregular periods. Abnormal cortisol levels, irregular periods. Body weight issues, BMI and such all factor into this. So it's not, you have to think of it as a constellation of different disorders that result in an ovulatory irregularity. So it's not one thing. And, you know, there may be natural ways as far as if BMI is an issue, or as Jill pointed out, insulin resistance is coming into the picture. There are plenty of natural things that can be done to regulate your cycles. But there are some medical conditions that need to be addressed if you're producing too much cortisol and so forth, that do need medications to correct. So I think that it's two parts. It's first the diagnostics to rule out medical conditions that may impact the regularity of your cycles. And once that's done, then I think it opens the doors to other natural therapies. So you want to be methodical. And I think it's a terrible name. I mean, they aren't cysts, first of all. That's always been a pet peeve of mine. They're follicles. They belong in the ovaries. Those are eggs. You don't want to be without them. So I don't know. This is an ancient name, and unfortunately, you can't change it right away because nobody will have any idea what you're talking about.
But it's worth saying, isn't it, that for testing these days, they take 2 out of 3 of the following. The little things that look like cysts, the follicles, the little string of pearls, or irregular cycles and elevated androgens, male.
Elevated androgens are part of it.
Yeah.
It's actually, the first part is, as you said, irregular menstrual cycles. Part 2 is the elevation or, you know, abnormality is in androgens. And that can be determined in your blood work, or it can be determined on physical exam if you have oily skin, excess hair growth, and so forth. It's the last part of it, part 3, which is the exclusion of other medical complications, including diabetes, hypercortisolism, hyperthyroidism, enzyme blocks, and so forth. There's a whole list of tests that are done to fill the 3 parts of that diagnosis. It's endlessly complex, and it's endlessly complex because we really don't know what it is. So I call it a garbage can diagnosis. It's like, well, whatever doesn't fit into this box, that's the box we have to treat. Unfortunately, that's the state of it.
It's a bit like IBS. That ends up being where everybody gets put with a nervous stomach or something like that. This is why we're good together, incidentally. Just anecdotally, before we leave PCOS, one of the things that I've seen, and I've done this a long time, is that people are more likely to hold a pregnancy women if they've had 3 months of regular periods with their PCOS. And I think it may be the effect of the androgens on the follicles, and as those levels come down and their periods get more regular. But I have noticed that if I can get to have 3 regular periods when they get pregnant, the egg appears to be of better quality. And that's somewhat anecdotal, but I just wanted to pass that on to you.
I think that's a great observation, and I agree with you. But I think that the reason is that once you're having 3 cycles in a row, that you're probably ovulatory and you're making good amounts of progesterone. And progesterone is very important to maintain the pregnancy. So I think once you've proven that you're ovulatory and you can make progesterone in appropriate amounts, you're going to have a better pregnancy. So I think that that your observation is accurate and on point. But I think we may want to move on. Or should we?
Yes, I've got a question here to me privately, and I just wanted to say it out loud because it's actually a good question. Katie wanted to know what supplements or lifestyle changes she can do to prevent chemical miscarriages. And I think we should probably start by saying a chemical pregnancy, as it's sort of known colloquially, is a very early miscarriage in some ways, an extreme or an implantation problem. And what happens, and I see these very regularly, is patients have a fertilized egg and it appears it gives off signaling, there is signaling, and so the period's a little late. You may get a positive pregnancy test for a day, if that. Sometimes you don't, and then you have a slightly heavier, more crampy, more clotty period after that. And occasionally that's just normal, actually. And there are a load of chemical pregnancies that go unnoticed until you start to focus like you do when you're trying to get pregnant. So it's not necessarily worrying. But if you have a lot of chemical pregnancies in a row, you need to see a doctor, and Dr. Mukherjee is going to tell you what he looks for. But we start to think about what causes implantation problems. So why wouldn't an embryo implant beautifully? And that can be chemical. It can be, you know, as in hormonal. It can be low progesterone, as Dr. Mukherjee just pointed out about successful PCOS pregnancies. It can be structural. You can have fibroids in there. You could have polyps in the way, things like that. It can be metabolic in some way. Very occasionally, and people get very into this diagnosis, but very occasionally it's an immune issue. And you're actually mounting an immune response against an embryo. It isn't as common as you would think if you read the internet, that in my experience, but it can be. And so a certain amount of detective work and troubleshooting needs to go on, doesn't it, Dr. Mukherjee?
Very well said, Jill. I think you covered all the important topics. And, you know, I think what I was talking about previously with PCO, it's a diagnosis that has, you know, people think it's monolithic, but it's broken down into all these parts. Well, recurrent miscarriage, even more so. When you think about the moving parts that all have to work in synchrony to establish a healthy pregnancy, when you start thinking about all the things that can go wrong, it's truly mind-boggling. And I think what a lot of people get comfort from is that, you know, when you get together with friends and family, they talk about the successful pregnancy. So you have a skewed view of just how able we are to have a healthy pregnancy, when in fact, even if you're in your 20s, you have about a 15 to 20% chance of miscarriage. And in your 30s, that number goes to about 20 to 30%. So the rate of miscarriage baseline is very high. Why is that? Well, even when you're young, half of all the eggs that are stored in the ovaries are chromosomally abnormal, as are half of all sperm. They're chromosomally abnormal. They don't have the 23 chromosomes. Or we have 46, egg and sperm have 23 apiece. So there are a lot of errors that are inherent in our biology, the way we are built, that we cannot escape. And in many ways, we can't escape this. So the question that we want to answer is your miscarriage rate greater than another couple of your age and your general health? So that's the important thing, because miscarriages are going to happen. There's nothing, even with IVF, that makes that rate zero. I can reduce it, but I'm never going to make it zero. So the question that I have to answer, and you listed them wonderfully. What's going on in the uterus? Is there a fibroid? Is there a polyp? What's going on with your general health? Are you diabetic? Is your thyroid okay? Do you have any medical issues that would compromise the pregnancy? And the primary areas are these genetic issues. But that last part, and you touched upon it, is very controversial, and that's the immune system. And the immune system is a puzzle to us all, because we can't do the research. No pregnant women in their right mind, and I would agree with this, would let the testing that needs to be done during the pregnancy, and rightfully so. We don't understand. I can't tell a patient once they're pregnant, well, doctor, this embryo, this baby is genetically different than me. Why am I not creating an antibody reaction to it? Well, I can state some of the medical research, but nobody knows for sure. Whoever figures that out is going to win a Nobel Prize. We don't understand why the mother doesn't reject the fetus. So it would be naive to assume that there are no issues that affect the immune system that increase your risk of miscarriage. Now, in the city, there are reproductive immunologists who I defer to in these situations. And essentially, it's a matter of exclusion, that we've tried everything. We've looked at their chromosomes, their embryos, their uterus, everything looks great, but they still miscarry. And to me, once I've excluded everything that I know how to treat, that's when I seek the recommendation of a reproductive immunologist. or recurrent miscarriage.
You mentioned something there, Dr. Mukherjee, that I wanted to pick up on because I think it's interesting. Synchronization. And I often think unexplained infertility in many cases is a disorder of poor synchronization. And everything has to happen at the correct time. A fertilized egg needs to ovulate at about the right time, about day 14, in order to have reached maturity. Now, I've had patients get pregnant on a day 5 ovulation, so there are masses of exceptions. But in general, it's good for it to be in the follicle and ovulate. And then you need that fertilized egg to go smoothly down the fallopian tubes. It's an egg to start with, and it meets the sperm somewhere in there. Sometimes people have gunky fallopian tubes, and that's why, incidentally, when people have an HSG, which is an imaging of their tubes, and they flush the tubes, they are statistically more likely to get pregnant afterwards. And it's because it's a bit like rotor-rooting, it's plumbing. It just sort of takes the gunk out so that the fertilized egg goes down in a timely fashion. And the reason it has to go at the correct speed is because your uterine lining, your endometrium, reaches the correct thickness and constituency for embryo implantation at a very specific time. And then the embryo, and this makes me believe in God, incidentally, this is sort of so amazing, then the embryo burrows and somehow knows how to do that and moves debris out of the way, and the fluid that it moves out of the way, it actually sustains it to start with. Which also blows my mind. But you can imagine getting all of those synchronizations to be right, to have your uterine lining to be absolutely in the perfect receptive state as a smooth movement of an egg meets a sperm, becomes an embryo, moves down, requires a lot of synchronization. And I actually believe that one of the reasons that Chinese medicine, including Chinese herbs, works so well for natural conception is that we start to regulate those kinds of synchronizations. And I wondered what you thought.
Oh, I agree with you 100%. I mean, the dance that must occur to have a successful outcome really requires a lot of partnership between various parts of the reproductive tract. You ovulate, fertilization happens 2 to 3 days after that, and that occurs in the fallopian tube. 2 to 3 days after that, that embryo enters the uterine cavity, and there is something called a window of implantation. If a healthy embryo gets to the uterus before that window of implantation, it's not going to attach and grow. If it gets there after the window of implantation, it's not going to grow. And studies kind of debate whether that window is 2 to 3 days or 36 hours. It varies depending on who you read. So you're absolutely right. I think what you can do in your office to help regulate cycles, to help synchronize ovulatory and luteal phases is critical, because we know that that window of implantation is a big concern. In fact, when we do IVF now, the majority of our cycles have shifted from fresh embryo transfers to prepared endometrial transfers, because guess what? When you're taking all those hormones and your estrogen levels are very high and your progesterone levels are not regulated in the fashion that they are during a natural cycle, well, that uterine lining is not optimal for embryo transfer. It works, but it's not as successful as it could be. So for the reasons you've outlined, we prefer now to take those embryos and freeze them, get a new lining, a lining that develops with the typical levels of estrogen that are seen during a menstrual cycle, with precise administration of progesterone, so we know when that lining is going to be ready. Our studies, and I think that this is confirmed with a lot of studies across the country, show at least a 5 to 6% improvement in success rates when you can get embryo development and uterine receptivity aligned. And as you're saying, your treatments help align these factors as well, right? So I think it all kind of dovetails very nicely. So I couldn't agree more.
Interesting. Because in Chinese medicine, qi becomes such an ephemeral topic, like what is energy? I wrote a whole book about it, as you know. You came to my book launch and it was very fun to see you there. But one of the definitions I give the patients of qi is really your body's intelligence. It's the way your body's systems interact with each other and synchronize. And that really is what your energy is. I can give you other more sort of woo-woo explanations too, but that's an aspect of your energy, is this ability to synchronize. And I think it gets overlooked. And I think it may be why a practice like Yinova has such good success rates, because healthy bodies with lots of cheese are good at that very thing, synchronizing. And I often tell people that I help people get pregnant by regulating their digestion. And, you know, guess what? Someone who digests better and gets nutrients from their food suddenly resources an embryo better, suddenly has a thicker endometrium. And, you know, there we are. I haven't really, in all cases, even looked at the reproductive system. I've just started with digestion, and sure enough. Liz has a question that I was going to have you answer first. I have low egg reserve with short cycles, but I'm otherwise a healthy 38-year-old. Is there anything I can do to improve egg quality? We get this question a lot, don't we, Dr. Mukherjee? I'll let you go first.
Well, I think that what you want to do is carefully look at the data that suggests that you have a low reserve. Right now, you know, when you take a look at it, it should be the result of age. It should be an evaluation of your AMH. It should be an evaluation of your ultrasound. It should be an evaluation of your FSH, also your family history. What age did your mom go through menopause? So you really want to kind of flesh that out. You know, again, low egg reserve is an open question. What does it really mean? If cycles are short, are you not making enough progesterone? So you want to take a look and supplement progesterone if necessary. To answer the question in the shortest fashion possible, there isn't much that we can do to improve egg quality. They are what they are. When you are born, you have about 2 million eggs. When you start to menstruate, you're already down to about 500,000 eggs. During your entire reproductive life, which you assume you're going to have 13 ovulatory events if you're ovulating regularly, you're only going to use 500 of those eggs. So this attrition rate continues throughout one's reproductive life. 38 is still plenty young to have a baby, but you want to get a better handle on what's going on to suggest that this ovarian reserve is low. Another way that I look at it is 10 years ago, out of 10 eggs, 8 or 9 of them were healthy. Now maybe 3 or 4 are healthy. So you still have healthy eggs. The question is, what can I do to optimize my pregnancy rate knowing this? And I think, you know, as this discussion has been leading to, everything has to be in balance. You do want to make sure that your dietary habits are aligned. You want to make sure that there are no other fertility issues. You can focus too much on egg quality reserve and then miss the fact that your partner's sperm count may be at fault, or not at fault. I never want to use the word fault. It's just Zoom. I'm getting used to it. That there needs another area of investigation. Or you want to take a look at anatomy. Make sure that the uterus and fallopian tubes are clear. Because even though your egg reserve may be slightly less, if all these other factors are lined up over time, you should still be able to succeed, because ultimately you will release one of these healthy eggs and it will meet with a healthy sperm. At 38, you have the time to explore these options. But if your cycles are low, you should have an evaluation, Yinova or RMA, to take a look and see if there's any thyroid issues, hormonal issues aside from egg quality reserves that could be a problem. And then look at your various treatment options, and you start with what's comfortable for you after you make sure your tubes are clear and your partner's sperm count is okay.
I agree with that. And I actually want to just add that I think there are sort of, I see on the internet some very false promises about egg quality. You know, take this supplement and you will improve your egg quality. And to a certain extent, they are what they are. And I often tell my patients exactly that there's good ones in there and we have to just maximize. And that means we have to be good every month. Yes, because we know that not every month is a winner necessarily. So we have to get timing right. We have to get all the other things around it right. We have to make sure that you're producing enough progesterone and things like that. And I do think that all the things you do to support your fertility, and one of them, it can be, I don't mean to plug my book, but we did write a program for different fertility types and making babies. And if you follow the program for your type, I think it's really helpful. And I think that can't change egg quality, as in the DNA of eggs, but I think it can help every egg live up to its potential. So if it has a potential to be a 6, it's never going to be a 10. But it could live up to a 6 sort of thing. And eggs that embryos that don't look amazing before IVF turn into beautiful children. Do they not, Dr. Mukherjee? Beautiful,
absolutely.
Smart.
Back in my office, I have a wall full of pictures of them. Not so much here.
Yes. Yeah, so it doesn't have to be perfect. Nature is amazing, and nature will, you're not trying to produce the perfect embryo, even though, we work in New York and everybody is trying to be as perfect as they can. So really, anything you do to support your fertility helps your eggs live up to its potential. And I'm going to skip down a few questions. I am going to come back, but someone asked a related question, Dr. Mukherjee, which is, do you recommend DHEA along with ubiquinol to improve egg quality, and how they mesh with, and I can't see that for some reason. Oh, I've lost you, but you see.
What, mesh with herbs,
yes.
This question? Yeah.
Yes.
I think it's a great question. I mean, we've looked at all of these supplements in general. The data for DHEA is reasonable. I would say that there have been a couple of studies out there that look at a dosing of between 50 and 75 milligrams of DHEA, and there is some suggestion that it may improve IVF outcomes. And the reasoning makes sense. The biological plausibility is there. In the ovary, part of what's required for successful egg development are androgens, because androgens are converted into estrogen. So DHEA is an adrenal androgen. It does have some efficacy in terms of acting as an androgen inside the ovary. So I would suggest that 50 to 75 milligrams of DHEA is not unreasonable. The data for ubiquinol is less convincing, simply because ubiquinol is an essential component of all metabolic processes in every one of our cells. So if we were not producing sufficient ubiquinol, CoQ10, we'd be in a lot worse trouble. So I think that there's no harm in it. 200 milligrams, 2 to 3 times a day, sure. But almost certainly, if you're talking or you can get into a Zoom session, you're probably making more than enough amounts of ubiquinol and CoQ10. So the support for that is less prevalent, but there's no harm in it. So I have plenty of patients who I certainly encourage DHEA. Ubiquinol, sure. I don't think that there's any harm to it at all.
I would add, though, that I think you should take advice about DHEA from your doctor. People take it a little cavalierly, and not everybody has low DHEA. Some people have very high DHEA, actually, and I've seen people then supplement and they start to get acne and
they get hair growth. You have to stay. You have to stay in those dosing ranges. Don't take too much DHEA. It is an androgen. You can have a lot of side effects. Start with 50. And then it's a 25 milligram tablet. So you can start with 50 and then increase to 75 if there's no side effects. But don't take any more than 75. That's going to cause some problems.
And if you're worried, and I think you should be circumspect about it, you could have your DHEA measured and see where your baseline is to start with. And if you have abnormally high DHEA, this is not for you. And the question also was, how do they mesh with herbs? And supplements and herbs work differently. Chinese herbs are very sophisticated. We practice what's called polypharmacy. So we don't prescribe one herb for one thing, a bit like in Western herbology, you'd have St. John's wort for depression. We treat a picture, a pattern. We're looking at the body's intelligence, really, and how different systems interact. So we create a separate herbal formula for every patient. And at Yinova, we do exactly that. We start with your base constitution, and we create a formula for that, and then we add in for different parts of the cycle and different symptoms that you're suffering from. And I will just say that our herbal pharmacy is up and running, and I know this because my husband is running it from our basement with my daughter at the moment. We moved all of our herbs up because our herbal pharmacy is very
I think you're oversharing. I think you're oversharing on that last comment.
Well, my husband is the chief clinic director at Yinova, so he's qualified to do this, and we moved all of our herbs up to our house in upstate when we went on lockdown, and our acupuncturists are prescribing herbs, and Noah, my lovely husband, goes to the post office every day and sends them to you, and Emma packs them up and she puts little love letters into the patients, and sometimes chocolate, which I'm not sure I approve of, but I get the idea. So someone here, Bethany, is asking a question about natural killer cells. No, that's someone else. This is Bethany. They've been trying to conceive for 2 years, endometriosis, had surgery to remove the endometriosis, also vegetarian, and you mentioned protein, and that's always been a concern that you don't get enough. and a diet to reduce inflammation due to the endo. I'll start because you'll have a lot to say about endo, but I will just say that endometriosis is a very puzzling disorder when it comes to fertility, because and also when it comes to pain. There are people with enormous amounts of endo who have no pain at all, and there are people with the tiniest little bit who are crippled with cramps with their endometriosis. And I think the issue is inflammation and mucus, two different types of endo there, two different subsets, but the inflammation starts an inflammatory process that gets in the way of pregnancy. The endo itself can just structurally get in the way too and start gumming up tubes and things like that. But I do think you're right to think about, Bethany, think about diet and how to reduce inflammation, because that is an issue when it comes to trying to get pregnant with endo. And we give herbs usually for endo patients. We can't make endo go away. We send them to a surgeon, but we are actually in the middle of doing clinical research when we got locked down. So we're not in the middle now, we're in limbo, but we're about to do clinical research where we have an endometriosis surgeon who is sending their patients to us, and we're seeing if we can slow the regrowth of endo, which I do believe we can. Her frustration was that she was seeing the same patients 2 years later and having to take the endo out again. And so we said to her, we think we can slow that down with herbs and lifestyle and regular acupuncture to improve circulation. And we have an acupuncturist at Yinova who's also a nurse practitioner, Brittany, and she's leading a program into endo. And I wondered if you could give me your thoughts on endo, Dr. Mukherjee.
Well, endometriosis is certainly frustrating. Taking care of a lot of endometriosis patients over the years, I think once you've sorted out the anatomy and reduced the extent of endometriosis, it's very frustrating that pregnancies have such a hard time establishing themselves afterwards. So anything that can be done to reduce the recurrence rate of endometriosis, much appreciated. Dietary modifications to reduce inflammation, also useful, but the best answer to this question is being a vegetarian is okay. Being vegan, where you're really eliminating a lot of protein, you should consult with a dietitian just to make sure that you are getting adequate amounts of protein in. Taking a look at your overall intake of foods to see if there are any pro-inflammatory foods that are there. So I think that you should consult with a dietitian for this. As far as endometriosis goes, my approach is yes, if you've had surgery, you undertake whatever therapies you can to reduce the extent of that disease while enabling you to still try and conceive. Because the truth of the matter is the 6 months to a year after endometriosis surgery is the most likely period of time where pregnancies will occur. If they don't occur in that period of time and you're not pregnant, then you want to look at medication, ovulatory induction agents, and moving on to IVF, because the critical issue with endometriosis is that it is an inflammatory disease. There is no question about it. And what I mean by inflammation is that as your cycle continues, you're making estrogen, these implants grow. And then under the influence of progesterone, they actually luteinize. And then when the estrogen and progesterone drops at the onset of the period, these implants don't have enough hormonal support to continue growing. They regress and they break down and cause inflammation. That inflammatory process continues throughout the menstrual cycle as the body is trying to clear these endometriotic implants. And the analogy that I like to use is the egg and the sperm are like a lock and a key, and the inflammatory mediators of endometriosis, like taking tissue paper and shoving it in the lock. It's very hard sometimes for natural fertilization to occur. So that's why, you give it time, you increase the number of eggs that are available for fertilization, because if there's 2 to 3 eggs instead of 1 egg, you increase the likelihood of fertilization occurring. If that doesn't work, IVF really does need to be considered in these individuals because of this inflammatory state, because you take the egg and the sperm, you put them into the IVF laboratory, they function just fine. And the other plus is if the uterus is healthy, which it is in the majority of endometriosis cases, it's a protected space. So you take the embryo and you put it into the uterus, and implantation occurs just very well. And, with Jill's assistance to make sure that your uterine artery blood flow is good, it all works together. But the important thing to keep in mind is after surgery, that 6 months to a year is the time to strike. Don't take off too much time after that surgery to try and conceive.
We rush people after that surgery if they want to conceive to a fertility doctor for that reason. And I would just like to say that if you're taking herbs at that point, you should see a specialist like we are for fertility acupuncture and not a generalist, because a lot of the herbs that they use to reduce endometriosis in people who aren't trying to conceive actually impede implantation. And so it's a very specialized job. You can imagine there's a lot of encouraging of blood flow and things like that. And you have to be very, very careful when you're treating a fertility patient, because we don't want you to take 3 months off at that point when you've had surgery. We want you to try to conceive straight away while that window before it grows back is there. And so as you're prepping for IVF, we will give you herbs, but we're hoping that you don't have to do your IVF and you'll get pregnant naturally. And to do that, it's quite a specialized job. So at Yinova, this is our thing. This is our job. We know how to do this. But you should be careful about who prescribes your herbs at that point.
Well, Jill, that's a very good point. That's why we refer patients to Yinova for that reason, because if you take the wrong combination of herbs, you're going to encourage endometriosis growth. You're not going to suppress it, you're going to encourage it. So you have to be very careful about that.
Yes, Dr. Mukherjee and I met when we were both on the same television show, and he had a problem where a practitioner of Chinese medicine had prescribed very estrogenic herbs to someone with fibroids, and it had made the fibroids grow. And I assured him that I would never do that, which I never would. But we know which ones of our herbs.
Well done.
I would never do that. But it's a very, actually fertility herbology as well as fertility acupuncture is extremely specialized. And Dr. Mukherjee will tell you that he gets nervous about people who don't know what they're doing prescribing herbs, not because they don't work, but because they do. And many of them have hormonal qualities. So you have to be well trained to do this. The Yinova team have been together for a long time. Many of us have worked for over a decade together, and we train endlessly and we keep up to date, particularly with herbal research. But it's specialized, and if you have any condition that gets worse with a sort of dominance of estrogen, which includes endometriosis and fibroids and PMS, funnily enough, then you need to see someone who knows how to prescribe herbs around that.
Yeah, no, I agree. These herbs can be very potent. I mean, birth control pills were derived from yams, right? And St. John's wort thistles, all these other things can be potent phytoestrogens. You have to be careful.
We had another question about immunology, which I think is sort of related in some ways to what we talked about with endo, because that does have an immunological component with the inflammation. And this is a question from Katrina, who says she has elevated natural killer cells and cytokine activity, and she understands that her next IVF or transfer may benefit from suppressing the immune system. But would this make her more susceptible? This is a very good question right now, to other issues, including getting viruses, which is obviously of extreme concern now. What do you think?
I think that's an excellent and timely question. It all depends on the type of treatments that they're using to modulate your fertility. Some of the reproductive immunologists that I work with do prescribe steroids for the use during an embryo transfer, and I would advise strongly against steroids. In our practice, when we do embryo transfers, we routinely administer a small dose of Medrol. We've omitted that. We've stopped giving Medrol now because of our concerns about steroid administration and compromising the immune system at this time. Other treatment options, like intralipids, for example, really shouldn't affect the immune system. Intralipids are essentially lipids that are given as a food source to patients who aren't able to take oral intake of foods and such. But when you administer it intravenously, it also mops up the antibodies that may affect miscarriage rates. IVIG is a blood pool, as a pooled blood product that is administered, and I would probably advise against it too, because we don't know about this virus, how long it's been in the population, and we can't be sure that a pooled blood product, not regular blood or plasma, but a pooled blood product, how well that's been screened for this virus. So I would have a very long discussion with the physician who's prescribing this. As I said, I would have no problems with intralipid. I would have a problem with general steroid use, and I would have a problem with IVIG at this point, unfortunately.
Yes, I think that's actually a very timely question, and thank you for asking it. I would say this, that we start to have to ask ourselves the question of why someone has elevated natural killer cells, and try to get to the root of it rather than just suppress, I think. And that, you know, that's my kind of job. I enjoy that kind of detective work, but I think that's safer right now. There are ways, Dr. Mukherjee's right, of suppressing that aren't going to make you more susceptible to viruses. But women's immunology is fascinating, actually, because we are in a state of flexible, sort of immunoflexibility in our reproductive years. And we have to be, you know, we have to fight off pathogens, but we also have to accept foreign matter, an embryo that is half not us. And it's actually extremely intelligent of our bodies to be able to do that. And I think I have a personal belief that women, as we get into perimenopause, often develop autoimmune disorders, including things like Hashimoto's and things like that. And I think it's because we have this very flexible immune system when we're younger by necessity that men don't have. And it as it moves from this immunoflexibility to being more just fighting off pathogens as we get older, we go through a stage, some of us, where we don't do that very well, and we start to get autoimmune disorders in sort of our 40s, late 40s, early 50s. So I think it's interesting. But if you were my patient, I'd be trying to get to the bottom of why you were developing these natural killer cells, and also how much this was genuinely affecting your fertility, because sometimes it isn't actually as much as you would think. Megan would like to know how to improve cervical mucus. And Dr. Mukherjee bypasses it, which is one way of handling it. So one thing you can do, there is a condition which I always think is horribly named, and called hostile cervical mucus.
Oh yeah, that's a terrible.
And which always makes me sound like it, I don't know, like it has teeth or something. But your cervical mucus, which you produce every month when you ovulate, and incidentally, this is so genius. It's the only time of the month when you're alkaline, like semen. The rest of the time, your vaginal mucus is somewhat acidic, and then it becomes alkaline like semen. And your fertile cervical mucus, I can wax lyrical about this. I teach gynecology, and I do a whole lecture on how amazing fertile cervical mucus is. It has little striations in for the sperm to swim. It has nutrition. It's sort of amazing stuff. And just a tip, honestly, more people have got pregnant at Yinova because I've told them this. Your last day of cervical mucus, egg white cervical mucus, is usually your most fertile. So I mentioned that in making babies, and it is true. So if you have the same amount of cervical mucus every month, like 3 days, you can sort of plan ahead a little bit, because that last day is usually if everything's synchronizing properly, your most fertile. So cervical mucus relies on estrogen, which is why actually some fertility drugs dry it up a little bit. Not that that matters, because they usually use them with an IUI and they bypass the cervix, and that's the end of that. So good, healthy cervical mucus doesn't come from taking a supplement just for your cervical mucus. It comes from resourcing your cycle from right at the beginning to support healthy estrogen levels through your follicular phase. And then you will have healthy cervical mucus. The only thing I would add is drink plenty of water, because you need to be hydrated to produce mucus. And don't take any kind of pills that dry up mucus, including high doses of vitamin C, which acts like an antihistamine and can dry up cervical mucus. I give a whole list of those in Making Babies, and I can't reel them all off now, but it is in the book. Or if you join the fertility coaching group at Yinova, which is a relatively low-cost option, you can, they'll give you that as a handout at some point. We're going to coach people through their fertility on lockdown in groups, Dr. Mukherjee. But that's how to improve it.
I think that's a great answer. And Jill, there's another question that popped up, and I think that would be good use of our time from Claudette, that asks about what is the relationship between pre-implantation genetic screening, advanced maternal age, and miscarriage. And if you don't mind, I'll just take a couple of moments to discuss that, because that is a topic that I'm very much interested in. So we know that as you're getting older, you have fewer healthy eggs and miscarriage rates rise. As I alluded to before, the miscarriage rate in your 20s is less than it is in your 30s, and even more so when you get into your 40s. In your 40s, the miscarriage rate can be as high as 40 to 50%, unfortunately. So what pre-implantation genetic screening, and now it's actually called pre-implantation genetic testing for aneuploidy, allows us to do is that I have patients in their 40s who make numerous embryos, 7 or 8 embryos. Once I screen them, unfortunately, in many cases, they are all abnormal. But once we can hit upon a chromosomally normal embryo that has the requisite number of chromosomes, regardless of age, whether you're 20, 30, or 40, your pregnancy rate is going to approximate 50% because we've taken off the table one of the most likely reasons that miscarriages can occur. Not the only reason. Miscarriage rates are still about 10%, but that's a significant reduction from the 40 to 50% rate that would be expected based on age in your 40s. So there's a very tight relationship between these issues, between miscarriage, increased rates of aneuploidy, and what embryo testing allows us to do. I hate to use this term, especially in this day and age, but it flattens the curve across all ages. I know that's a poor choice of words these days, but that is in fact what it does. And we had it first, where we can normalize across the decades pregnancy rates by finding embryos that are most likely to attach and grow. So we are a very strong advocate of screening embryos, certainly in your 40s, to allow us to find that healthy embryo for you, because that's half the battle.
That's such a great answer. And I think the value of pre-genetic screening is also, as you get into your late 30s, early 40s, it prevents you from having these miscarriages from which waste a lot of time and are emotionally and physically extremely draining. And if we can protect you from those, we would, wouldn't we, Dr. Mukherjee? So
it's, you know, it's all these years that I do it, and it still gets to me when a patient has a miscarriage. It's unfortunate. People struggle and struggle. They get a positive pregnancy test, and unfortunately the pregnancies are lost. It's a terrible thing. And I wish I could prevent them entirely, but I'm happy that I can reduce the risk of them occurring. That makes me happy.
Yeah. And that's such a good use. I would send anybody for that kind of, if you're going to have fertility treatment, just being able to sort of edit the embryos in some way and find the better ones is a huge value and more likely to increase your success rates than just about anything.
100%. 100%.
Yeah. Yeah. Well, I was thinking that we should just do one more question and then we have to go, but it's been really fun. And I just wanted to say before we take a question that we don't normally have time to chat with you like this, but we do when we're on lockdown, and we should do this again because we have
a lot of time on my hands.
To tell you. That's why I wrote Making Babies, because I felt in the clinic I was always just going from one patient to the other, and I had lots of knowledge I wanted to impart. And one of the things that we're loving doing at Yinova at the moment is we're doing fertility coaching, and we have like 5-year doctorates or 4-year masters, all of us. So we're not just your average fertility coach, and we have a ton of experience, and we never pass this experience on in this way. And it's such a good use of lockdown. So feel free to have virtual consultations with us. And I'm going to give you a tip before we take our last question, which is that our new fertility coaching group will be announced at the end of this week. So nobody has, it'll get full and it has limit. And Emma already got one person who'd heard a rumor that we were doing one and asked to be put on the list. So she's number 1 on the list. But if you email Emma at Yinova.com, that's EMMA at Yinova, YINOVA.com. She'll pop you on the list for the first coaching group before she sends out a mailing. And it's going to be led by a woman called Ambran, who I have worked with for 12 years. And she's going to take people through the 3-month program. It's going to be an 8-week coaching group, and she's going to take them through the program in Making Babies for your fertility type, and she'll answer all your questions. She's so smart, and we're going to run them regularly, so if you don't get into this one, you can get into the next. We'll probably start a new one every couple of weeks because we have time to impart some knowledge. Which question would you like to take as the last one, Dr. Mukherjee?
Oh no, I'll let you choose.
Okay.
I think we've answered a good number of these.
Oh, Bethany, you can do this anywhere in the world. It's the beauty of Zoom and coaching. You can join the Yinova Fertility Coaching Group no matter where you are. and we would love to see you. I've been talking to patients in Barcelona and Paris. I say to my husband, I sit at my desk, but the world is now my oyster. I can just do fertility coaching from my desk to everybody.
Jill, there is one question here, if you don't mind me. I know we're running out of time. There's a question about donor egg and whether you should be doing a frozen cycle for that as well. You know, that's a great question, but remember, with donor egg cycles, typically the embryos are created. If you have a fresh donor, for example, the eggs are harvested, fertilized, and then frozen. So by definition, most egg donation cases are already done with a prepared endometrium because you're not taking medications in the case of egg donation to stimulate the ovaries and in turn create those really high estrogen levels. So it's not considered an FET, but it's a prepared lining with an egg donor cycle. So you have nothing to worry about in those situations.
Good answer. And I have nothing to add to that, except to say thank you so much. I have known you for so long, Dr. Mukherjee, and we have not done this. And it's so fun if we combine our knowledge. And I feel like we really help people.
I've had a good time. And if anybody has any questions for either of us, you can get a hold of me by my email. It's my first initial last name at rmany.com, tmukherjee@rma of NY, and just say we spoke on Zoom. So I'll remember you.
And I'm just Jill at Yinova.com. I'm easy to get hold of. Just Jill at Yinova. And I haven't seen new patients for a decade, but I am seeing new patients for fertility coaching actually online. So I am happy to chat with you, and we can Zoom one-on-one, and I can look at your case in person. So thank you so much, all of you, for coming. I think we should do this again.
One last question. Do we recommend we try naturally at home during the pandemic? Absolutely.
Yes. Life will go on. We'll all get back to work. And I think it's an excellent use of your time. I'm literally coaching patients through my book, Making Babies, because I'm thinking, well, we may as well take this time to get you as fertile as possible. That would be a great thing to
get on Amazon right now. Get that book and stay at home and try.
Yes. And, you know, you may as well have sex, people. We're all stuck at home.
Yeah. All right.
All right, love.
Stay safe and healthy.
Bye.
Bye.